Today's lecture is about documentation and workflows. And Justus Adamson and I were both medical physicists. He's from Duke and I'm from Stanford, but he unfortunately had a conflict and he could not make it today, so it'll just be me. And usually what happens is we do a round robin of documentation and workflows. So the idea was that some of you would send us documents and we would review them and maybe point out some suggestions or improvements, but we didn't actually receive many documents this time around. So instead, what I decided to do is I'm going to go over the Stanford documents and our workflows, radiation, external beam radiation therapy. And we're going to point out good things, bad things, and maybe look at ones from the past. So this is a pretty short lecture. So I think if the more interactive it is, the better it'll be, because we have some time if we want. So Aggie, this will be very familiar to you. And so feel free to jump into things you like or you don't like since you've been here with us for a while. So some documentation at Stanford. So we are a paperless environment. So, this is pretty common now where, most of our documentation is done digitally. We use a Varian. We're at a Varian shop, top to bottom. So for those of you who have Varian and ARIA, some of this will look very familiar. And one of the things about ARIA is that it has very different kind of functionalities that you could use within ARIA. So there's these things called encounters, which you can think of like a checklist, but it's got links to different parts of the electronic health record. It's got questionnaires, which are just checklists, and you can embed actual physical Microsoft documents into the electronic health record as well. And there's also journal notes and other things within ARIA. So personally, I think it becomes a little bit messy because there's so many different ways of recording patients' information. Essentially, it's a mixture of functions. Sometimes you use an encounter, sometimes you use a questionnaire, sometimes you use a document. And even within a certain task, you'll be doing two or three different things. So personally, I would love to clean that up and make it a little bit more standardized of what we use. Our treatment record is recorded through the Varian record and verify. So you'll see at the end that we don't actually write down like MUs anymore because the system is recording that constantly for us. And one thing that I want to say too is that I have a recent role at Stanford, which is this quality improvement on the physics side. And what that means is that a lot of the time when things go wrong, when there's a miscommunication in the department, it falls to the quality group that I'm part of. And this was a really kind of enjoyable for me putting these slides together because I can wish for all these things to change and show you guys how to improve them, even though clinically we can't change them as easily as I can on this slideshow. So for the next, half an hour or so, I'm going to take you through the workflow at Stanford for an external beam patient, starting with the simulation request, right? So the first step in a patient's journey is our sim. And at Stanford, we've taken the simulation request and we've split it into essentially two parts. The first part goes to a person who's doing the scheduling. This is a scheduling instruction sheet. It's actually, you can see it on the right-hand side here. This is usually like a nurse or an assistant or a resident that puts this in. It's got a lot of good things on it. So it has information about our pacemakers, since a lot of the time we want to know that a patient's got a pacemaker really early on in the process, because a lot of the paperwork takes a long time. We have to coordinate tests for the pacemaker to ensure that we don't damage it during radiation or during simulation. So that's a very nice feature. You can see the information up here. Oh, you know what? I'm going to switch. Okay, there. There's also an area for coordinating patient factors, things that we should be aware of before the patient even enters the clinic. So a lot of this information is quite good to have early on for the scheduler. One thing that's bad about this is that a lot of this information, as you'll see in the next slide, is actually repeated in the actual simulation order that the doctor puts in. So this is like a nurse resident puts this in to give the scheduling an idea of what to expect. And then there's a second part that's the actual documentation for the simulation. And so I'm going to talk about this a few times where if you have documentation in your workflow or in your system that lives in two places, it actually doesn't live in any place. So basically, if you're documenting the same thing in two places, it's very poor communication because it gets confusing and it can become very difficult to figure out what the truth is. So this is for the scheduler. Next comes our simulation order. So this is what the doctor puts in. The simulation order is actually split up into like two sections. The MDs, the attendings, will be filling this out usually. The good part of this document is that, it has obviously the things that we need for simulation, like the simulation type is very clear. We have special machines that we have to be aware of, so we put them on here. The number of fractions is very useful because then it gives us an idea of how much time on the machine we have to kind of think ahead, even at the simulation. I really like this little bit here for the IV contrast. Not only are we choosing, yes, I want contrast, but because at Stanford we do a lot of multiple scans for each patient, this allows us to indicate which scan should we be putting injecting the IV contrast for. So those are the kind of the good things. Bad things, as you can hopefully appreciate, this is a very, very busy document. There is so much information on here. We're constantly we have this incident reporting system where anybody from doctors to therapists can submit issues that they have, like miscommunication. So we get a lot of reports submitted from our staff about things on here being missed. And then, this patient comes in for simulation, and then they find out, oh, he has a pacemaker, or he's, he needs anesthesia, things like that. So this is because this document is so busy, and a lot of the information on here, like the interpreter, like I think there's a pacemaker, paging instructions, they're actually duplicated from the previous sheet. So again, if documentation exists in two places, it's not very good. So this is the first kind of special considerations part of the simulation worksheet. The second part is this automated templated drop-down list that we use. So we basically have made sub-documents for every single anatomical site. And you can click on it and it'll create a nice standardized anatomical template for the simulation, immobilization, and positioning and the scan types. So this is wonderful. I recommend that, if you don't have this somehow built, whether they're independent documents or anything like that, this is a very nice thing to standardize the treatments and simulation. So this is an example for a thorax, for example. You can see that the patient positioning, the arm positioning, head and legs are all predetermined. Likewise, this chunk for the actual immobilization devices is also pre-selected. So we use a wing board, arms up with a knee fix. The scan types are also pre-selected for this. So this is like a SABRE type approach. So we definitely want a 4D scan, and we do an inhale breath hold scan as well. We have borders, which are mid-mandible and below lungs in this case. Slice thickness, because this is SABRE, we want nice small slice thicknesses, and some special instructions that are pre-populated. So again, this would be for the thorax. If you selected like the breast, it would have slightly different things. If you selected head and neck, it would have, the long mask and the clarity board, for example. So it's very nice. It forces a lot of standard approaches to the simulation if you have these anatomical templates. So that's wonderful. The bad thing about it, is again, this sheet is a little bit busy. It's not very clear to see what's selected and what's not. And so let's say that the doctor chooses a thorax arms up, but decides to add in an exhale breath hold scan. Well, because people are so used to the template being the same from patient to patient of that type, it's sometimes very easy to miss that something's been changed because there's no way to highlight that. So we're going to work on that in the future. So that's our simulation order. And I'm going to present to you, actually, maybe there's a better way. So actually, this is Justus's slide. And I really like their simulation order. They call it the physician order from Duke. So this is how theirs looks. It's got most of the same information. It's still busy, but at least it looks a little bit cleaner. I feel like it's much more organized than ours. Again, you could imagine that you could have one of these templated for different anatomical sites so that physicians aren't having to select things manually. You could very easily make this, you can see that there's the contrast section is nice and clear and it's got a lot of detail in here. So I actually really like that their sim order is a little bit clearer than ours and it's a little bit nicer. And you can still make these into anatomical templates for different sites. This is their second page. I think they have one interesting thing that they have is they have the fusion information. So often, you want an MRI or a PET scan or a previous diagnostic scan merged in your treatment planning system. So they put that on the actual simulation order, which is kind of interesting. And they actually put on some imaging information as well, which I found that's kind of interesting. The last thing I really like about theirs is I love this picture. For us, we just list like the words, let's say mid-chest to mid-thigh. I think a picture is worth a million words. And so I love these little diagrams. It's very easy for a therapist to see what they're scanning from if it's not standard. So if you have the ability to put these pictures in, I would do that. And I think in the future, we'll probably add that to ours as well.
I just wanted to add something, Peter. I think that the templated versions, as a trainee, it's super helpful. If you have a lot of trainees in your centers that are putting in these forms, then it's probably not a bad idea to for the physicians to sit down and decide if they treat thoracic patients the same way or simulate them mostly the same way every time. Yeah, so that's what it looks like. It's not a bad idea to do the upfront work and kind of create these standardized templates based on if you're going to do breast left side versus right side. Because then if you open it up as a trainee or new, starting physician, it's an easy foundation and you can always add and remove things as you need. Also wanted to add that I really like the picture of the body because sometimes that's the difficult part, figuring out where to scan. And sometimes I have to go back and open up the imaging of the patient to see where the tumor is and try to figure out how big or how small to make how big or small of a CT scan to get. So it's super helpful to just have it there on the simulation sheet. Yeah, this part.
Yeah, thanks. And yeah, like I said, the templates are wonderful. And the cool thing is if you have it templated where every anatomical site the doctors have agreed we're going to approach it this way or that way. If you change something in the future, let's say that now you've realized for liver, it's really, really beneficial to have these biphasic scans that show up their liver lesions really well. Well, you can very quickly edit your template. And now you know that every liver patient that comes to SIM from now on will by default have this. So we've done this in the past where we've wanted to change the scan resolution or we've wanted to kind of extend things. So it's quite easy to then standardize the change as you move forward. Okay, so now the patient has got their skin scheduled and they come in, they get their simulation done. And so this document is our simulation documentation. So this is filled out by the therapist who've done the simulation. We have the target site, we have what kind of simulation was performed, whether there was a CT or a PET, and you have the contrast that was used, the position. I really like this little bit. Again, I mentioned very often we're doing multiple scans of the patient where you don't have just a simple, if we don't need to, it's just going to be one line. But often we have multiple scans. Like in this case, we have a 4D, an inhale, breath hold, and a free breathing scan. And what's very useful here is the number of slices and the series number and the labeling that's done on what the intent of that scan was. Of course, the therapist will label the CT scans on the actual scanner. So there will be that label, but often that gets mixed up. And so this is a very good catch to make sure that what we think we're importing is actually what we're importing, right? So that if they labeled or if they forgot to label the actual CT scan on the machine, I know the series, I can go here and I could see, okay, this was a free breathing CT. So it gives us a really good ability to double check what was actually done on the machine. So I really like that. The other thing that we do, again, because we do a lot of gating and respiratory motion, so we take scans, the 4D scans, inhale, breath hold, and exhale, breath hold, we put that information directly on here. And so you can see for this patient, for their 4D scan, which is like a free breathing scan, they were very good, right? So they were regular breather, they didn't do anything crazy. However, for their inhale, breath hold, they seem to be pretty inconsistent. So the therapist wrote a little note here saying, this patient probably shouldn't be an inhale breath hold candidate, even though the physician added that to the SIM and the SIM requisition. and we scanned them because the patient could do it, this gives us a good idea for when we're planning the treatment. Maybe we shouldn't be planning the patient in the inhale breath hold state, even though maybe the anatomy is favorable, like for a breast, maybe the heart moves out of the way, or in a lung, maybe this makes our volume a little bit smaller. But if the patient can't consistently hold it as they were assessed in simulation, probably it's going to be a very difficult treatment during the actual therapy part. So this is very useful to tell us what's happening. We also put in a lot of photos. I didn't show the photos, but down below here, we have lots of photos of the patient set up, including all the marks and things like that. So I think the more photos you can put in, the better it is in case something goes wrong. You can always look at the photos to see how the patient was set up. So these are the good things that I like about our sim sheet. A couple of things that I think we could really improve is we put in all the immobilization and any notes to ourselves in this box right here. So everything is hand typed, it's free text. And again, in my position of this quality person where I get all these reports of people being confused or, setting up a patient incorrectly, this is a big part. It's free text. People forget to write down the wing board. Then somebody has to look at the pictures and maybe didn't notice it, or the vac bag is placed incorrectly because they forgot to put in what table index they added. So I don't love the fact that it's a free text up here. So is there a better way? So I'm going to show you an example from one of my previous jobs. This is what was filled out at simulation in my other job, which was this, we called it a setup instruction. This is an example again for a breast. So these were very templated, very locked down documents. And as you can see here, there's this part, the blue part was filled out by the simulation team. And you can see all the different immobilization devices were pre-selected. They were not free text. You basically had to click through and make sure that every single one is chosen. And so there's no way to, forget to type something. Like you go through and you have all these not pre-selected, but basically, you're forced to address these rather than in this case where it's free text, you could forget something or mistype something. Whereas here it's very, very clear. And so I feel like this is a much better approach. And I'll talk about this. So this part here was filled out by the simulation team. And this part down here was filled out by the planning team. And this document then was sort of the setup document that the therapist would always work against. And I'll show you, we don't do that. Okay, so now that we have a patient that's been scanned and we have the planning can begin. And so this is obviously the physician, the attending will do two things. They'll put in what we call a clinical treatment note, but it's essentially a planning directive and a prescription. So this is our clinical treatment note or planning directive. And these are wonderful. Again, they're very standardized. So for every site, whether it's breast, whether it's lung, this is an example of a lung saber sheet. They clearly outline what we want for coverage, how we want, whether we want the hotspot in this case. We have different OAR or organ constraints that are both ideal and required. So this is your minimum. This is, can you achieve that ideally? For every OAR, and these are very long sheets, they get very busy, but they're wonderful because they're very detailed. And so for a planner, I know the moment I see this is a 4-fraction saber, I just have to follow these criteria. And again, the physicians attendings can always customize these, but these are what I'm trying to hit. So these are wonderful. Again, they're templated, so it kind of forces everybody to have the same treatment planning approach, or to a degree, makes the planning very, very nice and easy. The one thing that I would criticize or would love to add is a priority. Is a priority. As you can see here, if I'm the planner for this case, and I'm struggling for some reason between the lung and the spinal cord, I don't know which one is more important in this case. So, I could push the dose away from the lung into the spinal cord, or I could push the dose from the spinal cord but into the lung. Which one's better? So I'll take a guess because sometimes it's obvious, but sometimes it's not. And so one of the things that I did in my previous job is that we had a sheet like this, which is very similar, but it had this importance factor. So as you can see here, it makes it very clear that the PTV, CTV is the most important thing. Meet these criteria before anything else. Next is my rectum. So if, let's say in this plan, I was struggling with both the rectum and the bladder, well, I know I can focus on the rectum first, make sure that I meet these criteria before I try and meet the bladder and femurs and so forth. So I really like this importance or priority. I'm not sure how you want to call it, but these are very, very nice so that when the planner is trying to meet your goals, this comes in extremely handy. Again, we had this similar thing where we had a stop and accept criteria, very similar to how we have this ideal and required criteria. This is very nice for a planner because I know I'm trying to hit the V68 to be about 5%, but if I can't really meet that, but I've met the 10%, then that's okay. That will be accepted most of the time. And the last thing that we also added to this sheet was this as planned column. And this is the dosimetrist or the planner would actually write, what did you actually achieve for this plan? So not only was it, did I meet this, but what was it that the plan generated for this constraint? The nice thing about this is it makes it very clear that if there's any, if any of these criteria are not met, or if they're, basically it's a nice record to say, yes, the physician agrees that these are okay. A lot of the time, this can be done inside your treatment planning system through like scorecards or like planning goals. Like there's different treatment planning software have different parts. So this kind of lives now in our Eclipse box as a scorecard. But I really like the documentation of this because it's very clear that yes, okay, maybe for this patient we couldn't meet the rectum DVH, and so this would be a violation. But it's very clear and it's documented. So the second part. I just
want to add one thing about the sheets with the targets. Yeah, this one. So it seems a bit daunting. Like, how did they get all these specific dose constraints? So most of these, like for example, our head and neck one, which is also pretty templated based on like what your disease site that you're treating, is it post-op, is it intact? A lot of it are just from clinical trial protocols like HN001 or HN005. So that's an easy place. It's like if there's a specific trial that's looking at like, 70 grade treatment, whatever dose constraints they use, some of our attendings or our physicians will just kind of copy in those dose constraints into these templated, like into the clinical treatment planning note. And so it's pretty easy. You just click at the top and you're following the specific protocol. Same thing for breast. Most of our breast constraints are also from trial. So that's a good place to start to figure out like what to constrain your dose to if you want to create like a templated thing across the board. And like Peter mentioned, you can always change it by like requesting something like more specific or a tighter, more conservative constraint if you want. And then in terms of the communication piece, yeah, I wish we had that, like priorities. It tends to happen on the back end. There's a lot of like email communication between the physician and the planner, but it's usually after the first draft of the plan has been done. So again, you could save time, like Peter mentioned. I wish we had this if you just communicated like what you want up front, what's most important. I find that it's usually the plan's done and then the physician says, well, I really want to spare the rectum so we can undercover PTV. And that's taking more time to like revise and edit the plan to kind of get it to the ideal conditions.
Yeah. Thanks for that. Yeah, exactly. I feel like on the planning side, you have to make this decision anyway. So often you're kind of guessing. You're like, okay, well, I know Dr. Aggie, she likes the bladder spared, so I'm going to do that. And then this time I guess wrong, and I just wasted like 4 hours of my time. So having these is really, really nice. Again, maybe when you're moving into the IMRT world, this translates directly to inverse planning. So it's really nice for when you're moving into the IMRT world, but definitely 3D, this is really useful as well. So the planning directive is one thing, but we also give add a prescription. And so this is what our prescriptions look like. Our prescriptions are not a document. They're like a built-in ARIA module called the prescription. So the big advantage why we use it, even though it's got some drawbacks, is that it links directly to a plan. And so if a prescription is changed, plan goes out to the machine, these patients being treated, but the doctor goes in and says, okay, you know what, I want to drop a fraction. They would go in here, change this, and that automatically prevents the old plan from being able to be delivered. So it's a really nice safety mechanism. So that's why we use it. It's a really nice from a safety perspective. So our prescriptions are pretty typical for 3D. So it has energy, dose, fractionations, the technique, how often we're treating. So this is an example of a SABR case. Excuse me, a lung SABR case. Includes things like the imaging over here. So you can see there's like imaging guidance. Bolus is also over here, if there was any bolus. And the nice thing that we're starting to do, which we're not there yet, but we're starting to really focus on these notes section for that to be a very detailed approach of how to treat this patient. So in this case, it shows a good example. You know, it tells you this patient has 2 different lesions. So nice. So it says treat on alternating days with the right lower lobe. Start with the left lower lobe. So it's very clear which one we're starting, and we're going to alternate between these every other day. You know, start with the cone beam, then use a fluoro to like evaluate the breathing motion of this patient. The gating, we have kind of templated gating approaches. One's called tight expiratory, which just means that the patient's free breathing while we gate around the exhale. Do you want to use oxygen? Yes, no, or if the patient needs it. So this is quite nice. We're starting to do this a lot better, but I think we've got a lot of room to improve to make this very clear of how we're approaching this patient. Some of the drawbacks of using this prescription approach is that there's limited space. You know, there's only so much you can type here. It's kind of difficult to see. You can't put in images or any formatting, things like that. And one thing that we're also struggling with, and this becomes a very important, again, as you move to IMRT and multiple targets, multiple PTV levels, is that these names up here, these PTV names, they're not linked to the plan or any of the contours in the plan. And so sometimes if there's confusion, let's say there's PTV, there's 2 PTVs, and that, you know, and we're reviewing an image, the therapists don't know which PTV to turn on. And so we're trying to make a way to basically make this very consistent, that whatever PTV thing is, this prescription is prescribed to, that's the PTV that you're aligning to, that exists in the plan. But right now there's no connection between these. They're just words, it's just text. So general observations. So in past, when we've had clinics submit their documents, there were some general trends that I pulled out from the previous presentations. So this is basically that for prescriptions, the 3D prescriptions are less specific than prescriptions in the 2D world. So in the 2D era, the prescription actually determined how the plan would look, right? So you would determine the gantry angle, collimator, the table positions, how big the field size should be in the wedges. In the 3D era, you don't need to do that because the plan will determine that. The dose distribution will determine that. So you're going to be actually a little bit less specific in your field arrangement information in the 3D world and the 2D world. And one of the things that often happen is that, you know, a lot of the documents that we've seen in the past, they're very open. Prescriptions are very basically just a handwritten text on a piece of paper. And, you know, handwritten directives or free text directives, like I've already kind of talked about, they could lead to confusion, right? The more templates that you have, the more drop downs or check boxes that you have, the better and more standard your prescription is going to be. Less room for error. So essentially what it should include pretty basic information like the total dose, number of fractions, the site. Modality obviously is important, whether you're doing electrons or photons, that should matter. Laterality is always very good. You can add general information and specific like instructions, for example, bladder filling or rectal filling, if it's not indicated in the simulation sheet or somewhere else. And, you know, essentially focus on things that will have a great impact on the dose distributions. Energy, bolus, if we want skin bolus. Dose information you can add into the prescription, but ideally they live in a separate document. Like I showed us our planning directives, that's where the dose and coverage might live. You definitely should mention if there's going to be multiple phases of treatment or adaptive replanning that happens on the fly. Constraints are important, but again, they could live in a separate sheet, as well as priorities are really helpful. Coordinating chemo is important. And then again, as you move from 2D to 3D to IMRT, imaging becomes like basically, you have to be very, very clear of how you're approaching the imaging of patients, since your PTV margins are essentially determined by how tight and accurate you can be during your imaging. Okay, so moving from the pre-planning to now we have a plan that's ready and it's ready to be given to physics and the RTTs. So the planner basically has a plan ready. And at Stanford, this is what we do. We essentially do give the therapists or give the team two things. One is a screenshot of our treatment planning system, and one is a very detailed report that has all the information they'll need. So ideally, this is the one that everybody uses because it really has all the information about the patient, about who approved what, the monitor units, all the machine parameters that are needed, the shifts that are included in here. However, the therapists really like this one because it gives them an idea of where they're treating. Like I think I mentioned in the first topic, moving from the 2D world to the 3D world, sometimes it's not obvious what we're treating. In 2D, it's very clear where the beam's going, that's where the tumor is. In the 3D world, and especially when you move to IMRT, that direct link between field setup and treatment kind of it's a little bit more cloudy because we can come in from contralateral sides, we can come in from all different angles. So this gives the therapist a nice visual representation. Okay, we're treating a big mass, rectum in this case. And so they really like the pictures. Okay, pictures are nice. Okay, so this we give them, and this is what they work off of to compare the plan to the plan that pops up on the machine. So that's the nice thing. The bad thing is we basically do at this step a lot of transcription. And so this is a busy slide, but essentially, if you look, this on the left-hand side, this document is our simulation document. So the information like the head, the immobilization information, that gets taken and gets transcribed to what we call a field note. For those of you with ARIA, you'll note that this note actually shows up inside the treatment vault. So when the patient's brought in for treatment, on a screen, it'll automatically pop up with this text. And so this gets transcribed, hand transcribed manually into this field note that shows in the machine. Likewise, any information from dosimetry, from the planning report, gets first transcribed to a journal note that's also easy accessible, but outside the room, and gets transcribed right here. You can see the isocenters, 15 sup and 5 right, that there it is here. It gets transcribed again into this setup note that shows up in the machine. This is a terrible step. So many times we get things wrong. People transcribe things incorrectly here, or dosimetry after the first fraction, let's say, changes something and says, you know what, it's better if we do something different. Now you have to update this across multiple areas. Things are forgotten. And again, if your documentation lives in multiple places, it's useless. It gets confusing. People forget to change things and update things. So I wish very, very much that we could change this, but it's a huge change for us. Again, maybe there's a better way. So going back to this example that I showed you of this setup note, this is from simulation. It's never changed. It's pre-populated. This over here gets filled out by dosimetry and physics. And again, it lives here. It's never changed. It's never transcribed. And then this entire sheet, we used to just pull up on a big monitor inside the room. And so this was I really like this solution. We tried it at Stanford a couple of times. People hated it. So for some reason, we're stuck in our old ways. But this is a better approach where you're only inputting the values. You're never transcribing things to multiple places. Okay, so treatment info, again, general observations from the previous lessons, from previous talks. If possible, it's best to directly pull this information out from your planning system so you can have customized reports. Again, do everything you can to eliminate rewriting things between sheets and between information. The screenshot is really useful. The therapists really like it. So I think that I'd be happy to bring a screenshot of the treatment planning system to anywhere I go from now on. And it should contain enough info that we accurately check against the plan that gets pulled up for treatment. You should be able to check everything you can dosimetrically against this document. So you have to include things like MUs, field size, etc. The shifts from the planning CT are very important. And so that and any other info should be clearly noted, right? There's a lot of things that go from the planning side to the actual treatment side that if it's not clear, it can lead to very big problems. So that transition has to be very, very clear. So the last couple things are the physics check. So I want to kind of go over what we do. So this is our encounter for physics. So this is called a plan check encounter. So we have lots of different items that we will check, like the prescription. This is the planning directive, and that matches the prescription. This is our treatment document, reference points, shifts from the dosimetry, and we do a QA second check document that we upload. But we basically go through and we verify all these different things. One of the things that we've built, and this is the custom built thing, is this automated plans check. You basically run this through a series of scripts, and it goes through and it verifies that what the physician ordered is what the plan reflects, that it was approved. So in this case, you can see that the plan was not approved by an MD. So for example, I had to go in and maybe reapprove it for some reason. And also in this case, the plan was not normalized. This is a VMAT plan, so the coverage was a little bit lower than what we expect. So this is wonderful. We've built this ourselves, but there is commercial software products that you could buy. I think one's called ClearCheck that can work with your system. And these are wonderful because they will catch lots of errors, and they really help standardize and make sure that every plan that goes to the machine is nice and appropriate. So this is our checklist for physics. And once we're finished with it, we move that plan over to the therapists, and they have a very similar one as well. They have one that's very similar, and they check things on their side. Like I said, dose tracking is done by our record and verify system automatically. So we'll go in here and we'll verify that the dose got recorded. So you can see in this case, we started with this 1p head plan for 20 fractions. Then we switched to this 2b head plan. Right now we're on the 9th fraction. After the 10th fraction, we'll do three fractions of this 3b plan. So you can see very clearly how these plans are being tracked. If you click on any of these, you'll get all the dose information, all the MUs, the dose to this point. Likewise, you can access imaging information down here. So this is wonderful. It's directly recorded by the record and verify, and the therapist just track which fraction we're on in their system, which is the last thing. So this is basically the therapist's daily treatment record. Again, it's an encounter, it's a checklist. They do what we call a timeout. Oh, I didn't grab the screenshot, but right here, there's a daily timeout. Every single day, they will ask the patient's name, the patient's date of birth, and what site we're treating. Patients get pretty annoyed because we're checking this every single day. Like, they've been here 30 times. Why are you asking me where I'm being treated? I'm a prostate patient. But this is our way to make sure we're not accidentally mixing up patients, because that's happened before. It's a big error. Every day, the therapist will review the prescription in case something changed, even though that we have an automated system to kick the plan out of being able to be treated. They will review the prescription. They'll review any previous notes that they've made to each other, and review setup information every day. So now, obviously, things change through a patient's course of treatment. The setup might change a little bit. Let's say that patient's arms hurt, so that we'll put a pillow underneath one of their arms when their arms are up, for example. So that gets documented in ARIA through 2 different ways. And this is, again, my kind of adage of, if documentation exists in 2 places, it doesn't actually exist. Sometimes we'll put it into a journal note. Sometimes we'll put it into an alert. And one of the bad things about this is that we're not standardized. And so it gets very confusing of where people should look if an update has been made. Ideally, I think, everybody puts them here, but sometimes therapists just feel like, oh, this is going to be an alert, and they'll put an alert. The difference is an alert will pop up as you bring the patient into treatment. But anyways, the point is that it's not consistent, and sometimes it leads to misses where a patient's setup has been changed, or like something, a therapist from the day before have noted something important and it gets missed because it was in a different place than somebody expected. So I don't love this, and I'd love to clean it up in the future. So again, looking back at previous talks, a lot of the time we're thinking about plans in the 3D era. In the 3D era, we think about plans rather than fields. In the 2D era, we really documented like field by field, whereas in 3D era and IMRT, you're looking at plan by plan. Dose tracking is very important, especially if you're going to do adaptive or multi-phase plans, right? So if you have, like I showed you in the previous slide, where we treated a certain plan for 10 fractions and then we switch, it's really important to track that dose information. we do it automatically through the record and verify. And then have a very clear place for how to communicate notes between therapists. Again, a nice clear document, not like ours, where they can live in multiple places.
We have a few questions in the chat before we continue. So the first one is actually something I was going to ask in a slightly different way, but from Vincent Shimanuli, he wants to know how long did it take for, I think we've been paperless for a while, but he wants to know how long it took to transition to paperless, to being a paperless department. So like completely electronic through ARIA or Eclipse. And then what was the uptake response from the staff? Maybe if you weren't part of the process at Stanford, maybe at your past roles, like watching that transition from paperless from paper to paperless, what the uptake, what the response has been from staff who are involved in that transition. And then for institutions and centers that are planning to transition to being paperless and completely electronic, what advice or lessons can you provide to them about that?
Yeah, that's a great question. And it's a huge, huge task. So it's not easy. I will say that. It's easy if you're starting from nothing, right? If you are starting a brand new center and you're going to go paperless, I think that's a much easier approach because you have nothing to fight against. If you have already a ton of systems, a ton of charts, physical charts that move around with the patient, moving that to a paperless workflow is pretty difficult. So I'll tell you, in my previous job, where some of these notes came from, it took us about 1.5 years of planning to make the transition. We had a team of about, I want to say maybe 15 people working on this, and it was very, very prescriptive. So we knew exactly how we wanted this to look. We didn't just recreate our paper documents in a digital way. We completely rewrote the entire thing with, very standard look, a very standard approach. Everything was a click drop down. And this took about 1.5 years and about 15 people devoted to it. It was a huge change, but it was basically done in one go. So it was like all this preparatory work for 1.5 years about, and then literally over a weekend, we said, this is the switch. And we switched to new patients coming in. So for a while that we were doing both, new patients were paperless, old patients were paper. But this was very challenging. At Stanford, when I came, we were kind of in the middle of this paperless transition. There was still a little bit of paper charts, like the dose tracking. We had a paper. I think the requisition was still a paper. And as a result, I think the difference is that because we did it kind of document by document, it's never as, I don't know what the word is, consistent or clear. The documents look different. You interact with them differently. Sometimes you interact with the document. Sometimes you interact with the ARIA checklist. Sometimes you interact with, an encounter. So actually, I preferred this kind of more aggressive approach where you sat down for a long time, you planned this out, you consulted, you tried it in a test, and then you went back and forth, see what worked, see what didn't. You took your time, and then you made a switch all at once. Versus, I think what we did at Stanford was we slowly changed from paper, basically replaced paper copies into digital copies. And I personally feel like that didn't work as well as it could have. And as a result, it's a little bit messy. Sometimes your things aren't consistent, but it's a very big deal. It's a very big task. And I think what my previous job did was we literally had, essentially, we reduced the clinical responsibilities of several people. That this is all they did for about 1 year, is really work on the documents and make sure that everything on the digital side was as polished as possible. So it was a huge, huge, huge task. There's another question for documentation exists in 2 places. I just mean that if you have something that exists in 2 places, it's not efficient, because if sometimes things can be checked off differently and they could be conflicting, and then the person who's reading this doesn't know which is the truth. Sometimes you update one and you don't forget to update the other, and again, now you don't know which is the truth. So I think one of the lessons that I'm learning is that if you are able to just have documentation in one single place and everybody knows to look there, it's much more safe than if you have multiple places where the same thing is documented, right? So a really good example is pacemaker. Our pacemaker is listed in the scheduling, kind of aspect. It's listed in the simulation order, and it's mentioned in our, like an ARIA icon. And sometimes one of those is missing, and then nobody knows, is this an actual pacemaker? Did we forget? Was this an accident? And so it's very unclear. If we only had one spot where the pacemaker information lived, then everybody knows this is the spot. Everybody looks there. Do we have a backup plan? No, we don't. So that's one of the huge disadvantages of going paperless, is that you don't really have a backup plan if your networks go down. In the past, when we know that there's a backup, there's an outage coming, you can plan for it by physically printing things out. But no, if our network goes down, or like you said, if there's a cyber attack, we sit, unfortunately. This is why I think like going to paperless is a much bigger deal than just the documents themselves. You really have to make sure your IT infrastructure is there, that you have very good backup systems, in case that something does go down, you can restore it as soon as you can. We have one of the things that we at Stanford have, and a lot of places do this now too, is we have like nothing's installed on the computers anymore. Everything is kind of through a Citrix web service. When that goes down, we do have a couple computers that are kind of connected directly to our ARIA system, ARIA database that we could use. But again, you're right. In terms of going paperless, you definitely become very dependent on how stable your network is. And if it goes down, you go down.
Peter, let's have you finish up for the interest of time, and then I'll try to consolidate these questions. We may not get to everyone's question. If your question isn't answered, please just email it to, I'll put a link to the RCC email chain, and they'll send it to Peter and he can answer offline. But we'll try to get to most of these. But for the interest of time, we may not get to all.
Sure. So actually, I'm finished. So these are the last two that I want to kind of highlight. We have a treatment summary that gets automatically populated from ARIA with some information about how the patient was treated. And this goes off to the referring physician or into the wider health record. And then we do something called a physics weekly review. I never did it in Canada, but we do it in the US here. But it's very nice, very helpful. So every week, the physics group will review the patient's treatment. Again, we built an automated system that looks and basically finds anything that might be wrong with the patient or with the treatments to that date. It gives us a little warning, and then we can kind of follow up. We review imaging, we review the dose to that point. And so, yeah, it's two small little additional things that are not really used for the patient workflow, but they're quite useful documents. I did see one question.
Yeah, there are a few more questions. So I'll group these two. So the first question is about what is the process for designing these documents, these like in ARIA? Like, what is the process? Who's involved in that design process? And then kind of tied in with that is, how are we following the documents in Eclipse or in ARIA? Are we using like care path for each patient? Or is there a different process to kind of monitoring or keeping track of them?
So I guess the first question is easier, so I'll answer that. So the design process it's team-based for sure. So I guess it depends on which document we're looking at. For example, if you're talking about this document here, which is the planning directive, this is very much for the physicians to agree upon. Physics or IT often help in like designing the documents, how they look, and actually putting them into ARIA and how they're accessed, but the content is definitely for the physician. In other aspects, like, this is a terrible example, or maybe this one's better. This one here, where it's the CT worksheet, the simulation worksheet. This is very much like the manager of the therapists, and maybe dosimetry and physics would play a role of what the content is. Again, what information do we want? How do we want the information to look? To answer the second document, or the second question is, how do we track this information, or how do we use these actually? So a lot of them are embedded into the encounters. So ARIA, this is a very ARIA specific approach here. So a lot of the time, this is an encounter. An encounter is basically link a document. So this treatment document, for example, if I were to click on it, one of the documents would get populated here. And then you can interact with the document on this plane. And then we approve all the documents. Once I'm finished with it, I approve it. So it locks the document down. And then if somebody else later down the road here as a therapist, if they want to see my work, they would click on verify treatment setup, for example, or verify imaging technique. They would click on that and the appropriate document shows up. And so they go through this checklist, and as they interact with ARIA, the different documents, they can check off that, yes, I've seen that, I can check that off, and it all gets displayed over here. Which is one of the things why I think we don't do very well, is that we do a mixture of check boxes, or what are they called? Journal notes, like down here, alerts. We do actual physical dynamic documents, like Microsoft documents, and questionnaires. And so the way this looks over here kind of keeps changing as you move through these different items, which I don't love because it kind of, yeah, it's visually not very consistent. I think the nice thing that my previous job did was we just said we're going to use everything is going to be a document, and everything's going to be an encounter that links to that document. So you get very used to how things look.
Awesome.
Then,
Peter, we had some other, yeah, I think that, and then the second one was about, did you already talk about the process of like how we monitor these documents?
So I guess, I'm not sure if I know. So we do use care paths to indicate to each other who's the next step. So yes, we use care paths for the planning procedure. So we have a pretty big care path from right from the start to the end. Everybody gets tasked when it's their turn to interact with the patient. So it starts off with the simulation. Once the simulation is done, it sends a task to our planners to import the scan, which then sends a task to the physician to start their contours, add the prescription, add the planning directive, and so forth. It gets basically pushed through a care path to each of the groups.
Yes. And so once a document is put in, so each document goes into a different bin. Like there's a documents tab within Eclipse and ARIA. So every documentation, if it's the simulation order or the clinical treatment planning note, or the physics for like brachytherapy, like the brachytherapy plan, it goes into this specific interface called documents. So all of the documents are kept there and accessible to for each patient, and they're accessible to everyone who's involved in that planning process. There's also a task pad, which is something that's a feature of Eclipse. So once something has been pushed from one phase, correct me if I'm wrong, Peter, like let's say the stimulation order is done and there's a contouring, the image has been like inputted into the contouring interface, a task pad is created for the physician and the resident. It will say PTV and prescription needed. So it kind of alerts the physician that, hey, this patient's ready for contouring and prescription. And once that's done, you can click and clear that task pad. Once a plan is ready, it'll create a new task called plan approval, or, PTV or plan approval. So there are different, as each care path process is moving along the line, there are different tasks that are created for the dosimetrists, the physicists, and the physicians. And then for the documents that are inputted, there's a specific place that you can go called the documents tab, and you can kind of review all of the documents. And that's kind of how we communicate with each other.
Yeah, yeah, thanks for that. That's really wonderful. And I do love the tasks and the care paths. They're really powerful. You can build very complicated systems, that really help with your workflow. I just want to show you really quickly if I can get my ARIA up. For some reason, it's not running. But if we have 1 second, if people want to stay, I'm going to show you.
While you're pulling that up, let me see if you can tackle this one. So somebody asked about, I'm not sure how are the numeric documents connected to the TPS system? Do you need
clarity? So they're mostly not. So I guess mostly not. We have created, so the documents do not connect to our treatment planning system ever. They will have to be hand filled, which is like, it's unfortunate. But we do have this automated script that creates a document that then we put into ARIA. So we do have a script that talks to the treatment planning system that checks all these different things. And then it creates a document that we upload to ARIA as a record. So there's basically the documents don't interact with ARIA, but we have a script that interacts with ARIA, or the treatment planning system creates a document, and then we upload that if we need to.
And then somebody asked if you have any information about Mosaic. We don't use Mosaic, but let's see if you've had experience. There's a question about, where is it? Here. So can you tell us more about Mosaic planning review system used in 3D and its relevance and importance? And then about good catches inventory for like, I'm not sure, good catches inventory for reporting. I think they just want to know about if you have
Our
any
reporting
experience
system.
with Mosaic as a planning system.
So I have very little experience with Mosaic. I know it's, at least at the time that I used it, it was not as easily integrated into the treatment plan, into the workflow as ARIA is, which I think is, at the time, it was like a shortcoming, but I actually don't have that much information about it. Sorry. For the second question about our incident reporting system, so we have, yeah, it's actually one of the things that is really nice at Stanford is that we have a very simple web page that anybody can access throughout the clinic, and they can upload exactly what happened. And it could be from actual incidents like, oops, we set up the patient incorrectly, to things like, you know what, I find this confusing and this is part of my workflow and I find it's not very useful to me. And we submit those workflow improvement requests. And so all of those things get emailed as they get submitted, they get emailed to a group. There's probably maybe 20 of us in this group. We decide which ones are important, and we basically form little subgroups that then will go and work on these problems, right? So if it's a big incident, right away we go and investigate, we figure out what the dose difference is, we talk to the physician to make sure that they're okay with what happened. So there's things that we do very quickly. But if it's like an improvement saying, hey, this is confusing, we form a small group, we talk to the person that submitted it to get more information, and then we basically try and see if we can improve it by changing some of our documents or changing some of our workflows. And then I just want to show you our care path here. This is like a recent change that we've made. Kind of show you, so this is basically the patient gets imported, CT scan gets imported here. Once this is done, it sends the task to the physician. And this is interesting now, from when the physician puts in their contours, at this point, we will call the patient and we will schedule the treatments. So we actually now, in the past, we used to schedule them during simulation, but now we're trying to explore changing this so that we actually call the patient and schedule their treatments only after the physicians have put their contours in. Because basically, we know and we now have the contours, we have the prescription. So this is where our basically scheduling point happens. So if there's a big delay between the CT sim and the prescriptions coming in, the patient doesn't even know. They don't have a scheduled date yet. So this becomes very fluid. This is the planning task. So this goes to planning when the PTV contours are ready. This goes to essentially, plan gets approved. It goes to physics QA over here once the plan is completely ready. And after physics QA, it goes to the therapist to start their final treatment checks. So this is what our care path looks like. And each care path, you basically take the task, you launch your encounter, and you start doing your checklist, which includes things to the documents.
Mm-hmm. There's a question about encounters. If we have any information on encounters in ARIA, like how do we use it? So briefly, there are so many different things you can use an encounters tab for. And Preeta, I think, is it customized? Can centers customize? Yeah. So it is customized. So for Stanford, we use the encounters tab to, like, once we put in a simulation order. So this is what we want to simulate, what Peter went through. Where are we going to take a scan from what borders do we want to scan? What do we want to treat? Do we want contrast? All of that stuff. That document goes into the documents tab. We also put in an encounter to create a simulation encounter. It's usually done by our nurses. You can use an encounter if you're going to create a change, if you want to change the treatment start date. So you wanted them to start this day. Now we want to delay because we need to get an MRI or the patient needs a biopsy. We can use it at the end of treatment. It creates what you call end of treatment summary, which is a document that we put into the patient's chart in Epic or in our EMR. So there are multiple different things. You could, every time there's a timeout at the machine, you create an encounter for that. If you're going to transfer the patient from one center to the other. So ours it's very robust. If you want to get insurance authorization, which is something we need prior to treatment, there's an encounter tab. So it's just basically creating creating a kind of a visit or a stop point for the patient. Peter, I don't know if you have more information. I think I'm mostly familiar with this from the clinician side, but I'm sure there are
Yeah.
physics and planning
So,
encounters.
so yeah, so essentially you got it right. So I think the way that you want to think about an encounter is, and this is how we did it in my previous job, and I think we kind of do it here as well, is that every time you interact with the patient's chart, like think about physically opening up the patient's chart is the same as launching a new encounter. So essentially, if I'm the therapist, the patient's coming in for treatment, I launch my RTT daily timeout. So I launch that. This is my task. This is my to-do list for this patient's interaction with this patient's chart. The first step is you always kind of, sometimes you interact with the plus sign, sometimes you interact with what kind of shows up. But in this case, I'll do a verbal timeout, date of birth, the patient's name, breath, and that's me. Okay, so I created it so it shows up here. This would link to the simulation document, so I could review the simulation document. I like that. This is any patient alerts would show up here. So this is a way to like basically interact with ARIA. Instead of jumping through each of these tasks or each of these modules up here, you could just create a very specific encounter for this person's interaction. So the daily timeout encounter looks very different than, for example, like the physics encounter. This is the one I use. Right, so this is quite different. It's got very different aspects because I'm checking different things than the therapist. Likewise, if the MD is going to interact with ARIA, I think there's actually the physicians.
Yeah, we have to put in an encounter. Well, the nurses, we have to put an encounter when we want to initiate treatment. Right? Yeah, that's how we kind of kickstart the process for the patient to get scheduled for the simulation, for us to get insurance authorization. This is how we communicate with the scheduling and planning team about what we want. So when we initially say, yes, we're going to treat you, we put in a simulation order, which is that document that Peter went over. And then we put in an encounter to kind of kickstart the process. Yeah, and so that's a sim order. Yep. Yeah. So so we kind of kickstart the process using an encounter. When the patient's done, we also use the encounters tab to do an end of treatment summary, which is there's an encounter called end of treatment. And again, it has a drop-down menu just to make sure you've done the necessary thing. Yeah, we kind of communicate, is this a standard? Like we want like a 6-day turnaround. Is this urgent? This patient's admitted. We need to get them treated and simulated within, a few days. We alert the authorization team to get insurance. Is it a standard insurance outpatient treatment, or do we want like emergent, urgent stuff? And then if the patient had prior radiation, we alert our coordination team to kind of seek out their prior radiation information, what is called a DICOM, so the prior radiation plan. We also use it at the end of treatment. We use it to communicate if the patient needs to get delayed. It's called like treatment simulation or treatment start change. If we need to make any changes to the simulation date or the treatment date, we kind of create an encounter for that. Yeah. And I think we got everything.
And honestly, I think the question is like how to use them. They're extremely customizable. So you can use them however you design. And I think this is where it goes back to when you're creating a paperless environment, it's just not just recreating the pages of the documents in a digital form. You really want to think about how your workflows are going to flow. Are you going to use encounters? Are you going to use care paths? Are you going to do one thing or another? What are you going to contain in each of these that you want? Because it does become very, very powerful and makes interacting with the electronic health record very, very seamless. So I think that's why if you spend a lot of time thinking about this with a group to make sure that it works, testing it out before you move into, before you switch your clinics, I think you'll get a much better system than if you just to take your documents and copy them into your system.
Awesome. I'm answering the last one. Awesome. Thank you guys. We're about 15 over, but I think we got everyone's questions answered.